Good morning, good afternoon, good evening, and good night. Um, uh, Hello to all of our viewers from all over the world. This is another episode of our Global Summit seminars. Today, I'm honored to have Dr. Jody Griffin um, with us for a very special, exciting webinar on implant dentistry and basically using a robot. So Dr. Jody Griffin, welcome.
Thank you. Thank you
Dr.
for
Jody,
having me.
thank you. Thank you. Dr. Jody Griffin completed his undergraduate degree from University of Tennessee at Knoxville. He received his Doctor of Dental Surgery degree from UT Memphis, graduating with honors. He has subsequently received extensive specialized training in dentistry, including implant fixture placement and advanced bone grafting procedures from Midwest Implant Institute. 1-year externship program on implant placement training at the Medical University of South Carolina in advanced soft tissue and bone grafting residency in conscious sedation at the University of Alabama at Birmingham. ACLS certification, oral and ID sedation certification from Tennessee State Board of Dentistry. It's an honor to have you, Dr. Griffin, here. And I'm very excited. I've had the pleasure of using Tomi hands-on personally, and I think it's probably one of them. I would say the only exciting thing in dentistry in many years I've seen. That it's basically something new. As an innovation that we definitely could use in dentistry.
Right. Yeah, absolutely. It is. A lot of our products in the last 10 years have just kind of been getting better. And this is the really first new technology to come to market in a while with this much of a bang for it anyway, the excitement. So it's a pleasure for me to be here. I'm glad to be speaking to you. So hopefully over the next about half hour or so, I'll give you just a glimpse of why I choose to use robotic guidance, and hopefully it'll spark a little bit more interest for people to do their homework and research and figure out if it's for them too.
Perfect. Perfect. So I'm going to share my screen for a second here, and Anshul, if you would, I would just want to talk about our Academy of Oral Surgery. Dr. Griffin, we would love to have you on our events. This one is on November 6th and November 7th. It's Saturday and Sunday. We have 12 speakers. All these guys are world-renowned surgeons, and it's basically about oral surgery and implant dentistry. So
Right.
I'll invite everybody to sign up for this event, and then we'll speak to you later about having you on this program for us.
Great. Do you want me to go ahead and share my screen to get started?
Yes, please go ahead. Thank you, Doctor.
All right. Yeah, you got it. All right, here. We should be go there. Y'all see that good?
Yes.
All right, great. So today we're going to talk a little bit about this robotic assisted, and this particular case that we're going to show is a full arch case, and we'll get into that. So here's my practice. I am a general dentist. I've been practicing personally for a little bit over 20 years, and been placing implants for about 18 years. Do anywhere from 250 to 300 implants a year, and actually have seen a significant increase in our implant business. I was the first robot user in Tennessee, and actually just installed a second one right up the street from me. So excited to see the technology catching wind. Robotics, and so actually that previous picture was that was the very first case I did, and this was an engineer from Oak Ridge who came. He actually had researched robotic implant dentistry, and he called our office before we were even ready to use it. But he was our first case. He volunteered to be our first case. So that's him in the middle after the surgery, and there's his post-op X-ray. This is the team that was there present when we started. So robots are nothing new. They've been around in dentistry in medicine for a long time. There's over 200 uses of robots in medicine and for all sorts of different uses. But currently, right now, we only have one for dentistry, and that is the Neosis brand Yomi. And Yomi is actually the name of the inventor, Dr. Moses. His there's a dentist that helped him design, and her first name was Yomi, so that's why it's called Yomi. Let's see here. So the robot, so Yomi, it uses haptic guidance, which is very different from XNav or any of some of the other navigational. And the haptic guidance is actually the differentiator. And so we also can preoperatively plan the case within the software. And then while we are doing surgery, the intraoperative approach, we have full guided. And so not only are the osteotomies guided, but also the implant being placed is fully guided. And it's for partially edentulous and fully edentulous cases if they are if they qualify for implant. So here I am in Tennessee, and this is actually an older image. There's now over 70 units in the country being used, and here is right when the first 3 cases that we were doing, and you can see I'm standing up. The robot is in place. You can see that on the screen, how there's live action. That's similar to XNav, where you can see it on screen. The difference is when you lock into position, you cannot come off of your osteotomy plane. So the actual guidance of the handpiece is non-adjustable once you start. Once you lock in the program, it stays locked in. And there typically is audio on this, but it's not coming through for this particular video. So sorry about that. I'm not sure why. We checked it before and it was. I don't know if you guys can hear it or not. So while robotics, so this is what I really like about it is all these green dots. So same day guided surgery. You don't have to wait on a surgical guide. It's minimally invasive. You do not have to elevate a flap if you choose not to. I'm kind of old school, and I typically do elevate a small flap. It's much significantly more conservative than my previous approaches. There is a physical guided plan, and as you're doing the surgery, you can see. Plus, there are audible alerts to let you know where you are, as far as different beeps to tell you if you're locked in, or if you've gone to depth, it gives you another audible. And then you use your standard drilling kits. You don't have to have all the guided kits and all the different keys. You can definitely see a lot better, what you'll see in a minute. The access in the oral cavity is significantly greater than if you have a static guide in. And then clinical and market leadership, that's not a reason to get it for sure. But when you're in the beginning of any technology, you get to be part of their growth and being part of the process of making it better, which I am a KOL for them. So this is an overview of the system. So a driver, so one of my driving assistant, she stands here and controls whether we're freehanding or guiding, and she controls all of that from this computer. This is for me to watch, and this is the actual shrimp arm that is totally guiding the surgery. And this, which is the patient tracker, it actually attaches to the patient. And that's the difference between XNav or any of the navigation systems versus this truly guided system. So the workflow is pretty simple. Patient comes in, gets a scan, you plan the case, and you can go right into surgery. And then obviously the restoration would come after that. In my office, we typically have a pre-op scan where we plan the case in advance, a couple of weeks in advance, unless it's an emergent case. And then we schedule, by the time the patient comes back, we've already got the plan and we're ready to start surgery. So here's our first case. This is an interesting case. This particular gentleman, we were actually going to do full upper and lower in sequence guides. And about 2 weeks before the surgery, he had a heart attack and was unable to go through the surgery. He got cleared about a year 9 months to a year after original surgery, and the in sequence stuff was no longer valid. They wouldn't guarantee it. They wouldn't send me the STL file to compare it to a new scan to see if it was accurate or not. So I decided to just turn it into a Yomi case, and we ended up doing just one arch at a time on him. He's now had both arches done and is in his PMMA provisionals. Here is my operatory. That's me planning the case at the workstation. I actually plan it now in my office, and then it goes into my network and shows up on the computer and in the functioning computer. There's a little bit more equipment here because of audio and video. We do a lot of live surgeries and things, and so this is cameras set up. But you can see the Yomi fits. And my operatories are very, very small. They were built in the mid 80s, and so the footprint's very small, and you can see that it fits just fine. So here is planning the case. It's like pretty typical planning software. Probably for those of you who are familiar with Anatomizer and Vivo, it may mimic that the most. Now this software has been changed. We're currently using it's Yomi 2.0 software, and it looks a little bit different. It's very functional, very intuitive, super easy to use, and it just walks you step by step, so that not only when you're planning, but also when you're performing the surgery, it's hard to get out of sequence and get out of order. You plan the nerves and the sinuses, everything the same as you're probably familiar with. And you can see in this case, he had lost a decent bit of bone, but we had plenty to work with. The anterior mandible was very narrow, which you can see there. Can you freehand these cases? Absolutely, you can. If I was going to freehand this case, I personally would probably elevate a pretty large flap to identify all the anatomy. So it's nice to be able to minimally invasive, minimal trauma to the patient, to be able to put these implants in without having to open them up from ear to ear. So it's really, I prefer it simply because of that. The surgeries are a lot quicker, a lot more efficient. And, we can do, in this case, surgically, our surgical time is less than an hour to put in 6 implants. So it's much more efficient than the way we were doing it before. And again, this is just showing the video of planning it. And again, we were speaking before we started, if you plan them wrong, they're going to be in the wrong spot. So you got to get proficient at planning the case. We actually had planned this from a preoperative denture and transferred that in. And so we knew where the implants needed to be. So this is the splint going into place for the edentulous case. It's just with striker bone screws. It takes about 2 minutes or less to put this in. And it's just with a straight hand piece, which you're very familiar with, tightening those bone screws down as tight as you can get them and as apical as you can get them, and understanding where your anatomy is on your pre-op plan. The new software, you can actually visualize where this splint is in place. And so you can see not only where the splint is going to go, but also if it's going to impede where your implant placements are. So what I really like about this is if you look at the picture, you can see the airway's not obstructed. You don't have a lot of plastic in there. You're going to be able to see the drills going in and going out. You can visualize everything. And so if you're doing IV sedation or oral sedation, you're worried about the airway, you've got the static guide and the stackable guides. You've got a lot of stuff in there. And when they did the FDA studies, the old surgeons that were testing this particular splint, they were much more relaxed because of the sedation aspect of it. They were able to visualize the airway. They could see their view's not obstructed. And it's really atraumatic as opposed to opening the tissue from ear to ear, reflecting the tissue all the way down the angle of the mandible, and then having to suture everything out of the way, put the guides in. That takes how much time before you can actually start the surgery? Quite a bit of time, where this is 2 minutes and we're jumping right into the osteotomy. So here again, just to see the difference between the trauma of doing a fully guided stackable case versus what we're going to be doing. And if there is bone reduction, you can actually, there's a couple of ways. We're going to have bone reduction in the software. It's actually there now, but you can create a horizontal implant to mark where you want to, how far you want to remove your bone apically, and then just use that as a guide. And so the bone, actually, in this case, we're gonna, after we place the implants in, I made a very small envelope incision, did what little bit of bone reduction I needed to do, and then sutured it back in around the multi-abutments, and you'll see just how much less trauma there is compared to our traditional way of doing it. This is a fiducial array going into place. This goes into the CT machine, and those beads, those silver beads, that's going to tell the machine where we are in space for our volume, for our work volume. Again, it goes straight to the CT machine, and he is not sedated. You can see the bone screws are in place, and that is a ICAT V17. It's an 8.9 second scan. This is the actual room. So it's performed in a standard dental office. You can have if you're left-handed, the robot can be set up for that. But the robot's on the left side of the chair in this particular case, comes over the top of the patient. I have one surgical assistant, one robotic assistant. The robotic assistant, she is the one controlling whether that machine is guided or if it's free-handed. And she's also, as we're drilling, she's calling out the numbers to me if I'm not looking at the screen so that I know my depths. The beautiful thing about this software is when you plan 10 millimeter depth, it stops at 10 millimeters. It will not let you drill further than 10 millimeters. And it also gives you an audible beep. So when you get into guided mode, when you lock into your plan, it gives you an audible beep that says you're in axis of the implant. As you begin your osteotomy, as you drill down, when you get to depth, it gives you 3 beeps, beep, 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 and that lets you know that you're at depth so that you could come out of the osteotomy. So that's the tracker in place connected to the splint. And that, as he moves, the skull on the screen over here also moves. I'm sorry that audio is not coming through. I checked that box, but let me see if I can. I'm going to stop sharing for just a second and see if I can get that audio to come back on. Just for a second.
Yeah, we're not hearing the audio.
Yeah, I'm trying to. I've got share sound checked. PowerPoint, share sound. Yeah, I'm not even hearing it through mine anymore. So I'm not hearing it on my end either. I'm not sure. I apologize, guys. It was working before, but it's not now. But as you can see, we're making our osteotomy. You can visualize the airway. There's a lot less in the mouth as what we're used to traditionally when we're using our guides. Yeah, that audio is checked. I'm sorry.
Dr. Griffin, since there's no audio, let me ask you a question here. So when you put the
Yeah.
guide, when you take the CT with the initial guide, when you screwed it, how do you ensure that that guide sits back in the same place when you're doing the surgery?
There's a check. Great question. So there's actually a landmark check, and so what you place the landmark navigation crosshairs on top of one of those bone screws, and then you go back and you place the tip of your burr onto the screw head, and it will calibrate to make, and you verify that you're in the right position.
I see.
That's a great question. Yeah, so it's called a landmark check, and you cannot proceed into surgery without doing that landmark check, whether it is a single implant. You would use a tooth that's not covered by the splint. So you would go to, I typically use a cuspid, and I'll go to the cuspid tip, and we do literally, she'll say landmark check, and you tell her what the length of the burr. So it's a 21 millimeter length burr. And then you go to where you place the landmark, and it will give you a confirmation number. It actually quantifies it and gives you a number. And so that way, you know, you're in the right position. Yeah, great question. And so you can see here, so a lot of times you'll get skiffing on those knife edge ridges. but you can see it just keeps the burr right in position, and that's pretty narrow ridge, and it just goes right to the place. So you're audible, you hear it, plus you visualize it and you get to see it. So the nice thing about this is I cannot get off of long axis from that implant, whereas in some of the other navigational systems, it's master slave. So yeah, you're seeing it on the screen, but it's not being controlled in any manner. So if you get off long axis or you put it in the wrong position, then you can do that. Where with it being haptic and physical, you cannot deviate from your plan, which means you got to plan it correctly, which we spoke about earlier. So here's the actual implant being guided. It's a very light touch. I'm not gripping that handpiece. I'm not, forcing it. I'm very lightly, just apically putting pressure so that the implant's guided in. So you can see with no flap, the implant's fully going to place. And when the implant gets to its position, again, you get an audible beep at depth. And I apologize that that's not coming through again, and then she hits free and then you lift right out. So it is fully guided, in that the implant is also guided completely to place. And then here's just taking the splint out, and those striker bone screws, which you oral surgery guys are very familiar with. And those are actually bone screws. They're not lag screws like our tenting screws or our membrane screws. Those are actual bone screws. So that takes just a couple of minutes to take it, or a couple of seconds actually, to take it out. And so here's our post-op intraoral view, and you can see it's a lot less invasive. You have very small holes from the bone screws. And I did like I said, I did a very light envelope incision and slight reflection to reduce just a little bit of bone, but there's a lot less trauma than what we're typically used to. And so here's our planned case. So you can see the position of the virtual implants. And then this is the post-op. So you can see now, if you look at the number 31 position, this particular implant's more distal than this. So when I put that implant in, I got a spinner, and it did not get any primary stability. So we stopped the case. I went back to the planning station, planned the new position of this implant, then back to the mouth and guided it in. The reason why I wanted to go ahead and guide it again is because of the infraocular nerve. I didn't want to freehand it. And so we planned it just by moving it a little bit further, under drill just a hair, and completed the osteotomy and placing of that implant. So as you can see, we have a fully guided 6 implant case. The surgery took less than an hour. The multi-unit abutments and healing collars are in place, and we sutured. So, that's a brief overview of how this works, and I'd certainly be open to any questions if you guys want. But, they originally, the Yomi was primarily for oral surgery, but if you have a skilled general dentist who has a lot of implant training, then I do think it can be implemented into the general dental practice. It allows for a minimally invasive full arch procedure. I use it for every implant that I put in. Is it overkill for some singles? Probably. It probably is. But I like the confidence knowing that it's going to be exactly where I planned it. If you look at some of the research and the data from pre-planned cases done freehand, had a 6 to 17 degree variation. And so it was 5,000 very skilled clinicians that still had a 5 to 17 degree variance in the implant. So I do think it's important to guide implants in, and I prefer to do it this way versus the static guides. Increase in patient volume, that's if you market it. And I'm close to Oak Ridge, which is a national laboratory. So we have a lot of engineers that have sought this out. And so we have had about a 25% increase in our implant business because of the robot. For those that want to be implant focused only, I do think it's a great adjunct to your armamentarium if you want to be implant only. And again, it's very accurate. It's very reproducible. And the feedback from my restoring partners is that the placement is significantly better for them. So, I like that a lot. I like the feedback that says, "Hey, I love, that the implants are exactly where you wanted them to be." So, I think I'm going to stop sharing my screen since that's the end of the presentation. But I think the technology is pretty phenomenal. I think it's the accuracy is amazing to me, and it's just getting better. The tolerances are getting smaller. So if you have your handpiece, then you put your drill in the handpiece, it's got a little bit of wiggle inside of the handpiece, and so they're redesigning the handpiece to get rid of that movement in the drill burr. It's going to be much tighter, which is very helpful going into knife edge ridges, being able to, a lot of times we flatten the ridge down before we do the implant placement, which I still do. But this, I can actually go in and then flatten it after I'm done. So I'm really enjoying the accuracy. The other thing I like to talk about is those of us that have been practicing for a while, we start to get back pain and neck pain from some of the physical contortion we do to get into the mouth, right? And so if you notice from those videos, I was standing up, my head was looking at a screen, maybe looking down in the mouth a little bit, but ergonomically, I'm in a better position. I feel better physically. I was having some C1, C2 problems, and then some hip issues from leaning sideways. And so those have completely gone away since I've been using this technology. And I've been using it since September of 19. So in about 2 years, I physically feel a lot better. So I think it's going to prolong the implant part of my practice. I'll be able to practice longer if I choose physically, which I was worried about a couple of years ago. So that's another added bonus, and not one that I even thought about before we bought it. But other than that's an overview of Yomi, and hope you guys are interested in learning more about it.
Thank you, Dr. Griffin. Yeah, it's amazing. Yeah, you're absolutely right. So, I guess for somebody who places 5 or 10 implants a day, I would say the number one concern would be how long can they do that every day, right?
That's right.
So that's absolutely a blessing to have such thing that, and I know that you guys are working on doing bigger things like zygomas and stuff like that. I know, so that's amazing, because that's I know for sure that's up and coming. A lot of dentists are already placing implants now. They're getting into zygoma placement, and that will be awesome, obviously, to be able to plan it out and just do it, because we're working in such a sensitive area.
Right. I think if you, especially the oral surgeons that do all the full arches like you guys do, the volume of full arches you do, I look at it as really helping you physically, takes the pressure off, because like we talked about, when you have to do all those huge incisions to get those guides, those bone supported guides in place, that's strenuous. It's hard work, and this certainly lightens the load for you.
That's amazing. It's amazing. One question: so when you do single, you don't do fixtures on a bone anymore? Is that your guide sits on the teeth?
Correct. It's a polyvinyl impression, and it's basically like taking a quadrant impression tray. So you put the polyvinyl inside the tray, you seat it on the teeth, and then there's a screwdriver that tightens it to a very light torque, and it has a clicking audible torque, and then the tracker attaches the same. So I really like it for like congealing missing laterals, or if I'm really close to the nerve in the posterior mandible, when there's the obviously the vital structures. So I use it for every implant I can. And that has made it, when we first started doing it, it was an acrylic tray, and it took 7 to 10 minutes for that to set. Now it's a fast set polyvinyl, so that stent's ready to go in about a minute.
Right. And me and Dr. Graffin we're chatting before we went live about how important the planning is. Obviously, I've done thousands of guided surgeries, and I thought I was crazy because I started flapping some of my cases, and I see I'm not. You said you do the same, so yeah, absolutely. Sometimes you don't get what you see in a CT scan, and it's best to do a minimal flap and look under, see where you're at. But absolutely, that's great. Yeah. So how long would you say it takes to plan a case like this for a single implant?
Oh gosh, a single implant, 5 minutes. They've got virtual teeth that you can drop in real quick if it's in a dentulous space. If the tooth is still there, I do a lot of immediates. And so if the tooth is still there, obviously you've got a guide, right? The tooth is going to help you guide when you're planning it. But if it's in a dentulous space, you can put a virtual crown in there pretty quickly. And to give you an idea, we're actually working on having the appropriate abutment with the appropriate emergence profile so that we have all of that in planning as well, and allowing your referring dentist to plan that with the actual abutment, the actual crown that they did design virtually, and then submit that to you so that you can plan the implant. So our workflow should be getting faster and faster, and then have a better referral source from your restoring doc to be able to really help you in that planning. You know, sometimes they send you a guide and you don't really know what the final is supposed to look like and that sort of thing. So I think from a software standpoint, we're going to make it better for communication between the lab, restoring dentist, and the surgeon.
Yeah, no, that's great. So you know, I would say even when they send you a guide or you make a guide, and you know, there's no bone. Obviously, that you know, if you're trying to do a screw retain, prosthesis, then you know the screw may come out on the lingual or buccal, whatever it is, but there's no surprise.
That's right.
Because you can actually show them, say, you know what, yeah, we can do this without grafting or without ridge augmentation, but this is what you're gonna have. That, you know, you're gonna have to.
Yeah, so I think if we can plan those together with the restoring doctor, he can see on the front end, yeah, that's where you want it, but it's not going to go there unless we do this.
That's right.
And so being able to do all that virtually and be able to see the actual abutment and crown before we do surgery, I think is going to help our restoring doctors understand what we're up against as the surgery aspect of it.
You know, that's great. That's amazing. That's amazing. And as far as so we talked about how long it takes to plan it, and then for placement. So obviously it's a lot faster. You talked about it a little bit. We didn't, you know, for a single case, is it like an immediate cases? You do a lot of immediate cases with it.
I do, yes, sir. So actually I had the team, the Neosis team was in Thursday, and they timed a case. So when I walked in, started the IV, from the time I gave local anesthetic till the implant was placed was 8 minutes.
Perfect.
And we've done them as fast as 4 minutes. Now, you know, I certainly wouldn't say that that's something you ought to do often, because, you know, fast isn't always better, but obviously it's much more efficient surgery time. And I think for the patient standpoint, the faster we can get them out of the chair, the better off they're going to be. The faster we're closing the flap, less inflammation, less post-op pain, et cetera. So the efficiency is great.
That's amazing. And so as far as the cost goes for, and is there a per patient cost for this machine as well as just purchasing the machine, or how's that work?
There is, yeah, and they're actually working on modifying it. The current it's $150, and that covers the cost of the splint. It covers the draping. It covers the few incidentals that you use during the procedure. So it's $150 a case.
Got it. And the team can basically modify whatever type of implant you're using, and they because obviously it's not all the same, right? Different.
Correct. The library, they've got a very vast library, and as long as the implant manufacturer has a digital library, they'll import it for you. When I first started, they did not have the implant that I used primarily, and they got that library imported pretty quickly. There is generic where you can create an implant, so you can put the dimensions in if it doesn't have an exact.
I see. Well, great. Dr. Jody, I don't have any more questions for you.
All right.
It was a pleasure to have you with us.
Thanks. Yeah,
I really appreciate you coming on a Saturday and on a Sunday. I'm sorry, on a Sunday, and taking your Sunday off, and
no problem.
To us, I appreciate it, and we hope to see more of you and have you on our symposium at the Academy of Oral Surgery.
Yeah, absolutely. Thank you for having me. And if you have any questions, please contact me or Neosis, and they'll bring it to you if you're in the United States. Right now, they can bring it to your office and let you demo it. So it's fun to play with.
Yeah, that was amazing. Yeah, so they brought it to my office, and and it was amazing. So I was able to try it firsthand, and do the drilling, do the placement, all that, not on a patient, obviously,
Sure.
but on a model. And yeah, it's amazing. And as you say, you cannot push that handpiece anywhere. Once you set
No,
it to where it has to go, and that's it. No matter even if you stand on it, it won't move
that's
because
right.
yeah, that's amazing. Yeah, the technology is insane.
Yeah, it is. And they're a very good company. They're great support. They've got a lot of, they're just a really good company to work with. Traditionally in dentistry, some of the companies we've worked with, the support's not been great, and they're fantastic. They've been fantastic to work with. Dr. Moses in Miami is a stand-up guy, brilliant. And so they're a pleasure to work with. It's been a breath of fresh air for us.
That's great to know. That's great to know. Well, we really appreciate you, Dr. Griffin.
Yes,
Have
sir.
a wonderful rest of the Sunday, and hopefully see you soon again.
All right. All right. Bless you guys. Thank you.
God bless you too.
Bye-bye.
Thank you. Bye-bye.
Yep.